Okay, thank you, Wendy, for that. I joined the GMTH team about 6 weeks ago, and as I said, my background, I'm a teacher, and before that I was in the military. My wife's a nurse. I've been married to the NHS since 1997. It's not there, okay. The thing I really like about it is we want to sort of be this fulcrum where if you need any help for your people or training, just touch base with us. If we've got support, if we've got funding, we'll either sort you out or direct you to it. But I think that the main sort of, my background's leadership, so we're looking at helping you as well to develop as leaders. So if you need any support with people or funding or training, come to us. We're a protocol to help you out. So I think that's the sort of overriding message from all the people around this room. Thank you so much for coming today. I'm going to pass you on to our next speaker. Could we give a round of applause to Jack Leach, please? Oh, good morning. Can everybody hear me? Right. Can everybody see the slides? Okay. Right. I'm going to talk about adult attention deficit and hyperactivity disorder. And the reason for this is that it's an important topic. It's under-recognised. And even where it's recognised, it's poorly, people have poor access to treatment. And there's a large number of people that are diagnosed but clearly aren't treatment. It has important implications for people's social and physical and mental health. And I think with current developments in general practice, we could actually provide a very effective and also economic service in general practice. Okay, how do I get it to move? Good, right. Right, let's, got it. Okay. Just want to provide an introduction about adult ADHD. I think people are probably more familiar with the child version. What is clear, it's a neurodevelopmental disorder that continues even in adulthood. I think where it's different in adulthood that people have the consequences of the condition when they were younger, they may or may adapt to that, and that may or may not improve their symptoms and their adjustment. Okay. Just say a little bit about ADHD. It's a collection of symptoms and features that is felt to be part of a single condition. There isn't a particular test for it, either a blood test or a brain scan that can actually say this is what you've got. So it's a collection, it's more of a syndrome than a specific disease. And it has sort of three major features: the inattention, hyperactivity and impulse control. And those can be combined in one or other ways. You can have single ones or combined. This results in easily distractible, unorganised, difficult listening, difficulty concentrating, keeping appointments. This might describe quite a lot of us actually, but it's a spectrum and a more extreme. It certainly describes me. Okay. The causes are known, but there does seem to be a family tendency for this. It's believed to be a neurological abnormality, although the specific details of that have not been recognised. So it could be to do with the neuroanatomy. It could be the way the nerves interact with each other and interconnect. It's often, I find it useful to explain to people, it's sort of they're wired slightly differently, and that results in different ways of viewing the world and the way they behave and the way they react with other people. There's a range of symptoms, as I've said, that can vary in severity and also can vary over time. There's also a problem that the symptoms directly relate to the condition, but they also relate to how people have developed and other parts of their life. It relates to their physical health. Unfortunately, can also be related to having the diagnosis of ADHD, and that can also alter how people behave and see themselves and others see them. And unfortunately, treatment can also sometimes have an adverse effect, but generally, as we'll go on to, has a positive effect. The diagnosis is based on a clinical assessment. There's various assessment tools that sort of guide people with this.
it can be difficult because there's certain features that can be common to other neurodevelopmental disorders, and particularly autistic spectrum disorder. And also there's various conditions that can arise from it because of the stress resulted from living with it, particularly anxiety and mood disorders. Just a brief history. It's actually fairly recently recognised as the syndrome it is, but it was first commented by Still. I don't know if there's any paediatricians here who recognise Still's disease. He gave his name to a disease. Still, that's a sort of juvenile rheumatoid arthritis. He was a paediatrician to the end of the 1800s, beginning of the 1900s. But even as far back as 1936, people were giving various chemicals to people to see if it helped. And actually, Benzodrine, a type of stimulant, did help, but it was largely a fad that disappeared. And the potential benefit wasn't actually recognised at the time. Ritalin actually has quite a long history. It's been with us for a while. Was first sort of approved to be used in 1955 in America, but actually wasn't widely used at all. Clearly, it's quite widely used now. The first features of where the sort of got classified as a condition is back in America in their diagnostic and statistical manual, which is their version of classifying all diseases. We tend to use the International Classification of Diseases, but they were first to put it in their book and give characteristics of it, although it has changed since then. And in the International Classification of Disease, that's from 2000, I believe, they classified it as the condition we know. So how common? This is actually quite difficult, really, because you can't go on the number of people diagnosed or the number of people treated, because that clearly underrepresents things. There was in this country, they have these psychiatric morbidity surveys, and one of them actually included looking for symptoms of adult ADHD. And they actually found quite a high prevalence, and 5 to 15% had features of this. This was self-reported, and it didn't take into account the severity. So that actually, to me, is quite common, and certainly a lot more common than people give credit. They found actually not huge differences between gender and also ethnic groups, which is again is a little bit against our current view of it, because it's seen as more common in boys and it's seen more common in certain ethnic groups. But that actual survey didn't suggest particular differences. But in terms of diagnosis, far more boys are diagnosed than girls with it. The average age is 7, although that can vary enormously, and many people with adult ADHD, probably around 50%, are not diagnosed till adulthood. Yeah, how severe? There's a marked severity both at the time when people are diagnosed and subsequently, and how people adapt to it. So it not only varies in severity at any particular time, but also over time. An encouraging part is that many people will seem to adapt to it, but unfortunately quite a lot won't, and they'll have the consequences of a difficult childhood and maladjustments of childhood that will continue to affect their future social relationships and job prospects. A follow-up study sort of demonstrated that, following up children. Again, that was those who were diagnosed, so it may not fully represent all people with ADHD. Right. So there again, it is incurable, but what is clear that things can be done, or things that can happen that actually modify the progress, that can either make it worse or make it better in terms of people's quality of life and their adjustment to their social situation. Right. Now this is fine, but is there anything we can do to help people with it? There's 2 treatments that have clearly been shown to be helpful. One's a behavioural approach based on sort of individual psychotherapy and family psychotherapy, and medication. Both have shown to be helpful, and they can also help together. You may have heard some of these treatments. They're a combination of some stimulants and also other non-stimulants that also seem to affect the neuroreceptors and systems that the stimulants also affect. There is concern about some of the stimulants because they have abuse potential, both by people that are prescribed them, but also by other family members, which has been concerned for some time. So how well do they work? Well, there's been Cochrane reviews that are very thorough. They do meta-analysis. They've actually shown that treatment is actually really quite not only effective, but is cost effective, because most of these drugs are not particularly expensive. Right. Is there any questions anybody had about that, the sort of diagnosis, how common it is, and treatment? Because I wanted to go now on to perhaps how, if you decide that it's worth identifying and treating people with this condition, what is the potential ways to do that? Is anybody on treatment? Okay, shall I carry on? The traditional way, and that is sort of suggested in various NICE guidelines, is a secondary service provided in mental health services and led by a psychiatrist, okay, which is fine, only it means there's very unequal provision across the country, and in some places there's no provision for seeing new patients or assessing new patients. And general practice currently are unwilling, pretty well universally, to sort of assess people and treat people with this condition. There's relatively few psychiatrists that take a special interest in this, and consequently will see, assess and treat people. Okay. Well, does anybody recognise this? Which American TV series is it from? Anybody want to have a go? Remember, this is probably for the older members of the audience. Yeah, very good, very good. So who are these three people? I'll give you a clue. One of them's actually passed away since then. In fact, two of them, the person in the middle has passed away. Anybody recognise these three quite famous actors? Michael Douglas. Yes. And Carl Marden and Kirk Douglas. So father and son, actually, as it happens. Okay. Right. There's considerable developments in general practice, including a wider range of health professionals working in general practice, and also an idea to be able to provide more services than traditionally general practice did. And I strongly believe that one of these should be providing an adult ADHD service with appropriate support from mental health services and suitably staffed that are trained, willing and able to provide it. Clearly, very complicated cases would continue to be managed in mental health services. But for the more, if I can call more straightforward, less complicated cases, I think general practice would be a wonderful site for this, and also probably see more people and be cheaper than in current provision. However, you could argue there's pros and cons. I think the pros, I would say, first is if you've got an interested group, it's nearer home. They can be more frequently seen and monitored, if need be. And also, you can use the actual GP systems, which I believe are quite considerably more advanced than hospital systems, and they're linked to electronic prescribing and to other health and social care services. So I actually think the information services, the staff, cheaper, could be managed, and one can also look after their other health problems, because quite often people with adult ADHD have other health problems, physical and mental health problems, as well as social problems. The cons, it's argued that there would be a lack of dilution of expertise, so you'd have a sort of larger number of very mediocre, less experienced areas, rather than concentrating it in a super centre. And also a study that where they have attempted this in America suggested GPs were more willing to prescribe other unnecessary medications, including antipsychotics and the like, that have potential side effects and don't actually help the condition very much, and were reluctant to increase the dose to a sort of therapeutic dose. So there are cons. Okay. So my conclusions from this are that ADHD is an important condition that has major implications for people. That it is treatable by safe and fairly effective treatment. That this can be done in general practice, and that would enable more people to be seen, assessed and treated and monitored. Okay. Okay, thank you. Any questions? Yeah. The gentleman at the back.
Is there the association of some genes in that group of ADHD, possibly you're coming to you for signs of this kind of disorder, possibly drugs in the family? Are there any questions available for that?
Oh, sorry, apologies, I didn't quite catch that.
I'm Dr. Khan. Is there any association of some gene, like people come and say it runs in the families, and some association for dopamine D4 and D5 in diagnosing these ADHD conditions? Any views?
Right, that's a good question. I think all I can say is there's definitely a genetic tendency, hence the family tendency, because that would be very difficult to explain, and I know it's been looked at to say maybe it's the early experience, family experience that has resulted in it, so that if someone is rearing a child who themselves has ADHD, is that more likely to create a sort of environment. However, even the best way is to look at identical twins that have either been kept together or separated, and they definitely show consequently some. In terms of the actual nature of it, as far as I understand, they've not really identified it, But there does seem to be some environmental factors as well. Hence the sort of why it's classed really as a neurodevelopmental disorder. There seems to be other things going on rather than just genetics. Yeah, the gentleman there.
Is there anywhere where there's a reliable guide to diagnosis? Because, like you said, there's the known symptoms, but there's a big overlap.
Right. Yeah. There's actually the NICE actually do include that. There's quite a lot of sort of diagnostic guides, including checklists. And if you actually want to look on the internet, you can actually do a self-check on it, looking based on symptoms. However, it's more than just doing that. You need to bear in mind there's other conditions which may be confused with it or may be complicating it, because comorbidity is common with ADHD. Yeah.
And I've just got this personal theory that a lot of people, it might be related to smartphones.
Right. Why do you say that?
Because you just get this attention span. With smartphones, you get the hit, the addictive hit of whatever you're doing on it, and so then that leads to difficulty concentrating when you're trying to read or when you're trying to focus on your work.
Right. Yeah. Maybe that's something to look into. Unfortunately, I'm not aware, because it's of difficulties changing the diagnosis criteria and things. It would be interesting to look at how it's changed, given changes in the modern world, how that's changed the prevalence of it. But tricky to do, because you ideally need it over quite a long period of time and need to have it so it's consistent. You consistently measure it over time. But it would be interesting to see whether modern things. Yeah.
Hi, very interesting what you said. I'm very curious, though, about a couple of things that were on two of your slides, which then you didn't explore. Right at the beginning, you said you were going to say something about the disadvantages and difficulties of the consequences of making a diagnosis, because sometimes labelling people, I wonder what you said about that. And also, you said something about the potential harms of the drugs, and then you changed the slide really quickly before I could read it.
Oh, right.
And I think one of the things that a bit links to what the person over there was saying that concerns me is the consequences of labelling, and when we focus on a treatment model rather than a social model, we cut out paying attention to the behavioural, maybe the mobile phone, I don't know, other social factors which are often driving this as well. Like I noticed in my own practice, it was often people who were poorer, who had less educational opportunities and so on, and it's easy to miss out paying attention to them.
Yeah, I agree, and it's reassuring that behavioural therapy has shown to be particularly helpful. in addition, it's helpful more so when in combination with medication. Sorry to sort of skip over that. I think it's very difficult because labelling theory is quite a history in sociology, and it clearly has an influence on people, how they see themselves, how others see them, and consequently adjusting their behaviour. And it's interesting, you probably find the same. We get those that are really keen on having a psychiatric diagnosis, both patients and psychiatrists. And then you've got others saying, no, don't do that. That affects them. It's best not to give them a diagnosis. And I personally think it's this pros and cons for either. I'm not aware of any research that says you shouldn't diagnose people with ADHD, and those that you should, and what effect that has on people's sort of how they are and how they progress. But it would be interesting to look at, but it's just very difficult since ADHD is influenced by quite a lot of things, isn't it? Not just the diagnosis itself. Now, to come to the medication, stimulants in particular, there's concerns about them because they can cause hypertension and affect heart disease and probably affect other organs. So the long-term use, the sort of doses they used are probably unlikely to have a sort of fairly immediate effects, apart from helping the condition, but long-term use. And when you're talking about adult ADHD, particularly when someone's been treated as a child and then transitions to adults, they could actually be on these stimulant medications for many years, and we don't know a lot about the long-term effects of them. And I didn't go into it, but then the question is, how long do you continue it? How much you adjust the dose? And under what conditions do you stop it? And I've yet to come across anyone that's sort of willing to sort of say what they think about that. Does that sort of answer your question? I think I covered.
Kind of, I think it's interesting that we're quite happy to medicate people permanently without really knowing consequences. That worries me quite a lot.
Well, I agree. And particularly in general practice, we're very good at putting people on medication and leaving them on them, maybe not monitoring them so well, and then being surprised when we discover they've got complications several years down the line. Yeah. But I think it's something we could probably monitor better, because what currently happens in some places, that they're seen in an adult ADHD service, managed for a while, prescribed, and then they look to get a shared care agreement. And I'm sure we've all had experience with mental health services. Shared care agreements means you look after them, you prescribe to them, and, well, maybe we'll see them if there's any problems sometime in the future, but we won't say when. So in a way, if we're taking responsibility, we probably should take the whole responsibility. Okay.
Hiya, can I ask, sorry, over here.
Yeah, oh, sorry. Hiya.
You mentioned before in terms of psychotherapy in combination with medication, and actually changing behavioural patterns and exploring patients' psychotherapy needs. Yeah. In terms of kind of waiting lists, we all are under no illusion here that mental health services, do need a big injection of cash, but you mentioned before them being managed better in primary care. We're setting up MSK services, we're getting advanced practitioners in, ACPs, to kind of alleviate certain workloads. Can there not be a hot hub for this service, and including sort of juvenile ADHD and mental health services? Because I've got patients now that have been waiting an awful length of time to be seen, to be assessed, and just starting somebody on medication without actually the cognitive side of things would be concerning. What other support is available apart from being on, an extensive waiting list to access and work together with other services? Or is that a vision that further in the future that's going to be set up? Yeah.
I think the answer to it, first of all, would be to ask the Mental Health Trust to provide a worker that then works in general practice, a psychiatric nurse. That's probably not going to work very well, because they're very pushed and unwilling to work in general practice. But where there is opportunities, primary care networks are getting funding for, as you say, MSK practitioners, pharmacists, physician associates, chiropodists, podiatrists. There's funding for that. I'm amazed that mental health practitioners hasn't actually come under there. And I'm still confident that it will do. The actual practice I work, we share a mental health practitioner with 2 other practices.
Right.
And when I sort of work with the mental health, I just started working with the mental health trust in this service. And my aim is to get it based in general practice, perhaps in my own practice, about our mental health practitioner training up and being able to support people with adult ADHD, as well as doing perhaps the other work, but particularly focusing on that. She was really keen on the idea.
I think it'd work really well.
Yeah. So if there was funding, because at the moment the funding that comes into primary care networks there's only a limited number of health profession it supports at the moment, contributing towards their salaries. But if it includes mental health practitioners, I think that would be good. And we could either second them from mental health services, or failing that, recruit them ourselves and ensure they get appropriate training. But that would help, because otherwise, at the moment in general practice, we would be a bit stuck for that psychotherapy side of things.
And just that mental health wellbeing support almost.
And that is
crucial to even compliance.
Yeah, I think you can do a little bit without the medications mentioned earlier, but not that psychotherapy and support there. Okay. Is that all right?
One over here.
Oh.
Hi, thanks. I was really interested by the presentation. I was hoping at the conclusion you were saying about, the need for a primary care service, that there would be one. But that's really interesting. I guess I'm just thinking about, there's a Psychiatry UK service that we seem to get letters about, the online London service. So one question is about services and the future of services, which I think would be ideal for GP with special interest in this. Yeah. And then just another thought really, for example, if I have a diabetic patient, there's a lot of advice that I can give them in terms of diet, in terms of lifestyle, and I think to quite a good level before sending them on to Desmond, where they get, really even more detailed specialist advice. But if I've got somebody that I think, may have ADHD, I don't really have much advice to give to them. Now, I guess my question is that a problem of my lack of understanding? Is there some kind of behavioural advice and things that we can or should be advising people whilst they're on their 1-year waiting list or 1.5-year waiting list? And are there any resources that you advise? Thank you.
Yeah, actually, I work in Bolton, and they haven't taken any new people for assessment since 2019. So that's bit more than 12 months, and the nearby services won't take people out of area, really. And that was why I got involved, because I was treating 2 people in shared care with I call it shared care, but had seen private psychiatrists and diagnosed with it, and it just didn't seem right to me. So my plan actually in Bolton is to set up a primary care service. At the moment, I'm working with the mental health service as a GP with special interest. Just started, but my plan is, I did tell them this, so that was my plan. So they still took me on despite that. I think it's because they're so desperate for GPs and other workers to be interested in it and be involved in it. Now, in terms of information, there is a national support group that I think it's always worth putting people in contact with. And there is quite a lot of information on the internet about it. And there's also quite a good book, which I can give a reference, that has sort of been written by, I understand, the parent of a child with ADHD, who then set up a support group and has written about their views about medication. It's very medically orientated, which surprised me, and tends to focus on the medication side, but it is a useful book which I can that gives their view and living with it. I think I can't remember the title, but I'll give you the reference. It's something like living with adult ADHD. It's called, but I can give that. So I think there is advice that we can give, but it just feels inadequate, really. Particularly when we say we don't know when you're going to get seen, and it may be a long time. That does feel very unfair when people are struggling and having problems in their lives. Okay. Thanks very much, everyone. All right.